Hey, how's it going? I'm Alan, and I'm an emergency and trauma physician.
And I'm Sue. I'm a pediatric emergency and trauma physician, and we both work with the University of Toronto.
Are you a physician or nurse in a community hospital? We know it's tough out there when you're managing trauma patients alone in your ED. In Canada, we face a bunch of challenges when it comes to caring for our patients in the Great White North. Geography, weather, and vast distances present unique challenges in getting your patient where they need to be.
No matter what, it's often a stressful situation, and if it's something that you rarely see, it's easy to find yourself lost in a sea of management decisions and inconsistent expectations from receiving hospitals, things like imaging choices and disposition.
Well, we are trauma-focused physicians, and we want to help you manage your patients.
Trauma has been around since the very beginning, but it hasn't been until this past century that we've been able to study it. How we think about trauma in modern times was born out of the creation of ATLS and its ability to provide a framework when dealing with trauma patients.
Let's start with a fairly common scenario, a motor vehicle collision. We have two general patient populations to consider. So you find these two patients in your ED recess bay. In this stressful environment, what are the decisions you need to keep in mind that will provide the most benefit for your patients, get them where they need to be, and take some of the uncertainty out of what can only be described as a very challenging situation?
First off, know where you stand. Be good at your primary survey. You may be all of the roles involved in a trauma resuscitation wrapped into one, but know the order you want to assess and address. Catastrophic bleeding, airway, breathing, circulation, deficits, exposure, and think about family presence. That's really important, for kids especially, as it makes our job easier by decreasing their normal fear and anxiety, as well as having important psychological benefits for their parents.
You don't have to be good at everything, but some things are a must. Know how to put in an IO and chest tube, know how to use a tourniquet and a pelvic binder, and how to reduce a long bone fracture.
If you have an ultrasound, learn how to use it for an EFAST exam. But remember its limitations. A positive FAST is helpful, where it can expedite the decision to transport and provides important information for your accepting doc who may mobilize services and resources early. Remember, a negative FAST does not rule out intra-abdominal injury, especially in kids. Keep in mind that repeating the FAST improves the utility of this dynamic test, as does combining it with other pieces of clinical information. Know your hospital's blood availability and how to get it. Check out U of T's Trauma app to find up-to-date guidelines for implementing or updating your site's massive transfusion protocol and other trauma-related guidelines.
In the adult world, damage control resuscitation can help prevent severe downstream pathology and coagulopathy that potentially worsens patient outcomes. Being comfortable with minimizing saline, palpable pulses, and a person who is coherent can be stressful, but ultimately best for hemostasis. Giving TXA as early as possible and keeping the patient warm helps support clot stability, but ultimately, blood and blood products are what should be given to achieve a perfusing blood pressure. The key indications include any suspected bleeding, especially with a systolic blood pressure of less than 90 or an altered level of consciousness.
This remains a controversial topic in pediatric trauma. Giving 10 to 40 mils per kilo of warmed crystalloid prior to blood is reasonable in pediatric polytrauma patients who present in compensated shock. But early administration of blood components is absolutely vital in patients who present in decompensated shock. Remember, hypotension is a late finding in pediatric hypovolemic shock that you want to avoid as it truly signifies a peri-arrest situation. Remember, if a kid is adult in size, treat them like an adult. But permissive hypotension is not an accepted principle in young children, and TXA is a consideration. We encourage calling a peds trauma doc early.
With so many elements to keep track of during a trauma, finding ways to streamline our decision-making and remove some of that cognitive workload can be extremely valuable. When it comes to the airway, significant morbidity can occur early without a strong focus on basic airway management. Once the decision to intubate is made, evaluate the potential difficulties and complications and have your backup plan on hand. If an RSI is indicated, we recommend keeping things simple. Ketamine at 1 to 2 milligrams per kilogram and rocuronium at 1 milligram per kilogram is a good place to start.
Some things to keep in mind for kids. We don't routinely pre-treat with atropine anymore, but having it available in case of a bradycardic response to intubation is not a bad idea when you're managing the airway of an infant or a toddler. Definitely remember post-intubation sedation and analgesia. It's best to have a plan upfront for ongoing needs. If a head injury is present in a child or adult, some key points must be taken into consideration. Avoid hypotension and hypoxia. Avoid hypocarbia. Consider osmotic agents like hypertonic saline or mannitol. Elevate the head of the bed to 30 degrees, but be mindful of your potentially spine-injured patients. Sedate and treat seizures aggressively. You may consider using fentanyl here in your RSI as a pre-induction agent. Lastly, avoid hypoglycemia. and check this early in the altered child.
Trauma hurts a lot. It's tough sometimes to know how much pain medicine to give. What's it going to do to that blood pressure? Will it mask any neurological deterioration? While analgesics can have physiologic effects that we are worried about in sick trauma patients, please do remember to also treat your patient's pain both in your resus bay and during transport. Options include morphine, fentanyl, and low-dose ketamine. In kids, managing pain and anxiety will help significantly with your ability to assess them.
Sending physicians are often given mixed messages about when to image and when to simply package and send. This can be frustrating and lead to delays in care at both ends. So to simplify, in the potentially sick patient, do imaging that you can act on, like a chest x-ray to guide chest tubes, long bone films to identify fractures that can and should be reduced, pelvic x-rays if you're suspicious for fracture, but if your patient is unstable, just bind the pelvis. Point-of-care ultrasound is quick, dynamic, and can help guide management at the bedside. It's a great tool to have for any ED community physician, but do remember its scope and limitations.
In Ontario, Critical Care Services Ontario Guidelines provides a straightforward list of indications for contacting a trauma doc for potential transfer. To be clear, we also recommend contacting a trauma physician for a support when faced with uncertainty in your department.
We as trauma physicians accept that we may receive some false positives, but knowing this will get sick patients where they need to go faster. The extremes of age should lower your threshold to transfer, as serious injury may be much more subtle in these people, as their physiology and comorbidities may present unique challenges to diagnosis and treatment. For patients needing C-spine immobilization, make sure the collar fits appropriately. Immobilization itself carries risk, and guidelines around spinal motion restriction protocols are changing. Backboards are meant for extrication. Consider scoop stretchers for transport, and realize that patients can spend a long time on these devices, which leads to complications. Don't let your patient lay around on a backboard. Get them off it as soon as possible.
Having a transport checklist provides a tool to ensure your patient has everything they need to be moved out of your department. Establishing alliances with your local trauma network to access feedback on performance and patient outcomes will make your team better equipped for the next trauma call that rolls through your door and will help trauma centers improve their overall care as well. So hopefully this information better prepares you for that next trauma. Till next time.